His weight is about 102 kilos. And since admission, so it's his hospital day 2, his urine output was 156 mLs. So this is hospital day 2.
In 2 days?
2 days. Now, nobody had made a phone call. It's one of those things that just kind of people hand off and, So the rapid response nurse was called to the bedside. And the reason that they called her was that there was a change in his mentation. His mentation was decreasing. And they noticed a few PVCs because he was on the monitor. And the question that was presented to the rapid nurse was, hey, I think there might be a change in the T waves.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today we're talking about pee. And yes, I know what you're thinking. Sarah, I want to learn how I can respond to emergencies. Well, what if I told you that you might be able to prevent the emergency altogether by careful and precise urine output monitoring? You see, the kidneys are such a good indicator of our patient's overall status. And when we can hone into how they are doing and apply the most up-to-date knowledge and technology to our care, we can often see badness coming and get interventions going before it's too late. So everyone who works with me knows that when I show up to an emergency, the next question I ask after how are the vitals is, how has their urine output been? Because it tells me so much about how sick the patient really is. Urine output is important. So let's talk about it. So joining me today to talk about acute kidney injury is a fellow pee enthusiast and critical care nurse educator, Tom. Welcome to the podcast.
Thanks, Sarah. It's great to be with you and everyone. That's pee is important. We don't like to think about it as important, but it's one of those things that gives us good information about what's going on with the patient. So yeah, I think we had some good information.
Awesome. Can't wait to talk with you. So before we dive in, can you just introduce yourself and share your nursing background and what you're currently up to in the nursing world today?
Sure. My name is Tom Colabro. I am currently the Senior Director for Surgery Services at Accuryn Health in North Carolina. And my responsibility is the operating rooms, the nursing staff, the CSTs, working with anesthesia, the surgeons. That's the biggest challenge, but that's another time for another podcast probably. And my background's primarily been in critical care, adult and pediatric, as well as in the emergency department. I've been an educator, taught at the collegiate level, which was great. I loved teaching nursing students. It was one of the best parts of my career. There's nothing better than seeing the light come on when you're trying to explain a concept, and it's probably the best drug there is in the world. So that's kind of what I've been up to in nursing, and I'm excited to talk to you guys a little bit about this today.
Awesome. So as a primer, can you just share what we know about AKIs and their correlation with morbidity and mortality?
So AKI is one of those things that's kind of flown under the radar for years. We talk about it, is they got a kidney injury or, they're going into renal failure. And as ICU nurses, a lot of times we say, they're in renal failure and now we've got to put them on CRRT or, they're going on dialysis. But the reality is that before we get to that point, a lot of things have to go wrong. A lot of pathophysiology has to take place. And so the main thing is that we know that AKI ranges anywhere in the hospital setting from 5% to as high as 32%, which is pretty significant when you think about it. A lot of that we also create ourselves in the hospital setting, the medications that we give, or most frequently, patient will come in and we'll have a situation where he or she will be admitted from the emergency department and their blood pressure is 170 over 90. And the resident says, oh, that's too high. Let's drop them down. They need to be in the 120 range. And they feel really good about the fact that we've dropped them down. But what happens is now that we've started that cascade of acute kidney injury. You'll remember there's different stages to acute kidney injury and how it's developed and whatnot. And so what we know is that acute kidney injury is responsible for a lot of mortality because if we don't catch it early enough, the patients end up deteriorating quickly. And when they deteriorate quickly, as you know, bringing them back from that is very, very difficult.
Yeah, absolutely. And especially for critically ill patients who their pH is so labile, and then we take the kidneys out of the equation and they can't help to buffer that whole system. It's very hard to turn patients around whenever their kidneys are not able to do their job. We've learned a lot about AKIs and their predictive value in recent years, but I don't feel like the value of close urine output monitoring was really conveyed to me in nursing school. I remember learning, notify the doctor if the urine output is less than 30 mLs an hour, which we now know is actually an outdated metric and not actually the best way to determine if there's a problem.
Right.
So 0.5 mLs per kilogram per hour is a more accurate standard because most of our patients are not 60 kilos. So I'd like to dive into the pathophys a little bit here. Can you explain what might be going on for our patients that would cause them to be making less urine?
Sure. So there are a few things that are going to happen with that. So I used to give a lecture in the College of Nursing, no BP, no PP. And so quite frankly, that's one of the things that happens is that patients become hypotensive. And because they are hypotensive, you'll remember the renin-angiotensin-aldosterone system. Remember that lecture? And everyone kind of went, oh,
that darn thing.
I hated that lecture. I had to get through that exam, right? But you'll remember that when we think about the kidneys, and we think about acute kidney injury, particularly, we go through different stages. There's the pre-renal, there's the intrarenal, and the post-renal. And so what happens is that these things start to impact our ability to make urine. And so what are those things? Well, a lot of times we use medications that are nephrotoxic. If we can get rid of some of those nephrotoxic drugs, that's going to make a big difference because what happens is it impedes the blood flow to the kidneys. We impede the blood flow to the kidneys. We're not able to filter that blood. We're not able to make that urine. And so we're not able to make urine. Then where does it go? Because that system is always running. Your body's always running. It's always trying to get rid of waste. And whenever your body can, it's going to make water to get rid of that waste. And as it tries to move it out, that's great. But if you can't, those kidneys can't function, it starts to back up. When it starts to back up, the stuff's got to go somewhere. Where does it go? Well, then we get into situations where we go into third spacing. They start the third space, it backs up into our lungs. And then if you think about it, you've got a patient who has got heart failure, my gosh, now the cascade is really getting out of control.
Yeah. Yeah, I like to call the kidneys the drama queens because just the littlest thing, and they get so irritated and upset. They don't have just the right amount of blood pressure, unhappy. They don't have just the right amount of flow, unhappy. They're very high maintenance, those kidneys.
They are. I'm thirsty. No, I'm not thirsty. I want to drink. No, I don't. I don't want to drink that. They're very finicky.
Very finicky. Before I hit record, we talked about good pee versus bad pee. Yeah. Can you elaborate by what you meant on that a little bit?
Yeah. So I used to work with a surgeon. I'd say, well, he's making urine. Well, how much urine is he making? And that we would talk about that 0.5 mLs per kilo per hour, which is a great measure. Are we making enough urine for your body size and for your body habitus? And so, if you're 60 kilos and you look around the hospital, there's not a lot of people that are 60 kilos. Maybe you're in a pediatric hospital, but most adults, and I'm in the South, we don't have a lot of folks in that 60 kilo category. So that 0.5 mLs per kilo is a much more accurate indicator. Now, the idea is that when we make that urine, is that quality urine? Are we getting solutes out? Are we getting things out of that urine? And how do we know if it's good? So we think about things like SIADH, and we think about diabetes insipidus. We're making water, but is it quality? Is it really being flushed through the system and we're actually getting the waste out? If we're not, then that's a problem. So too much urine, as we get closer to that urine's the specific gravity of 1, that tells you, well, that's not really great. If it's really concentrated and dense and dark and amber, really dark colored, that tells you there's not enough volume in there too. So we've got to add some volume. And then we look at how much of that urine is being put out. All those things come together. That's what I mean by good pee or bad pee. Does it look good? And is it being effective? Are the kidneys working the right way to clear the system of waste?
Gotcha. So can you talk a little bit more about the predictive value of urine output? Like if we see urine outputs declining, we know that's correlated with poor patient outcomes. But why is it so correlated with poor patient outcomes?
It's correlated with poor patient outcomes because as we start to see the urine drop off, what is happening is we're starting to see a renal failure that leads to another failure within the systems. And so it tells you that we're not perfusing appropriately. And so what that does is it starts that cascade of other failures within the system. So we would look at it and we'd say, here's a patient who may come in with pneumonia, and then all of a sudden he starts to have an issue. And we'll talk about a patient with pneumonia a little bit. He starts to have issues with his kidneys because he's not perfusing. And so what happens is then we start to see a change in mentation. We start to see a change in their ability to manage other systems. As the kidney injury continues to get worse, and that urine starts to continually get worse and worse, what we see is up to 30% mortality in some cases. So when you think about how many patients are at risk for kidney injury, you think about how many patients come in and they need to have urine monitoring. You think about how many patients come in with cardiac disorders, who come in with other issues like trauma. All of these things come together, and then we start to wonder, how is the best way to take care of these patients? Then this is where all this is going to be important.
Okay, so I think that's a pretty good foundation as far as like understanding the predictive value of AKIs and how it can be such a big deal. It can be such a huge hit to the patient's homeostasis when the kidneys just can't do their job. And so with that in mind, I'd love to dive into a case. Like, do you have any stories that would exemplify the kind of like typical course of an AKI and then the role of urine output monitoring and caring for that patient?
Yeah, I have one for you. This was an interesting one that we encountered not too long ago. It's a 67-year-old male with a long history of hypertension and coronary artery disease and had CABG surgery approximately a decade previously. He had been admitted 2 days ago after a wellness check from the neighbors. Nobody had seen him. And so they did a wellness check and they found him in his house, in his bed, somewhat non-responsive. He was admitted to the hospital. Through EMS came, they admitted him to the ED, and they found that he had a community-acquired pneumonia. After some cultures, they found it was an MRSA pneumonia, and so you started on VANC. And so he's up on the floor, pretty much an unremarkable course for a couple of days, and then the nurses on the floor called a rapid response on this fella. Now, he was on 4 liters of nasal cannula, sat in about 94%. His respirations are in the 20s, heart rate 96, S1, S2, no murmur, no gallop, no rub. Blood pressure is 118 over 60. And his Tmax was 99.8. And his weight is about 102 kilos. Since admission, so it's his hospital day 2, his urine output was 156 mLs. So this is hospital day 2.
In 2 days?
In 2 days. Now, nobody had made a phone call. It's one of those things that just kind of people hand off and, So auscultation of breath sounds, they were noted to be coarse, with wheezes noted and some crackles to the bases. So, that's consistent with our diagnosis, right? With our pneumonia diagnosis. So the rapid response nurse was called to the bedside, and the reason that they called her was that there was a change in his mentation. His mentation was decreasing, and they noticed a few PVCs because he was on the monitor. And the question that was presented to the rapid nurse was, hey, I think there might be a change in the T waves, but I'm not really sure. Could you help me out with that? And so, so the rapid nurse gets there and she takes a look at this guy, and immediately she becomes concerned when she finds out that the urine output had only been of 156 in approximately 34 hours. So it was hospital day 2, as we said. Okay, so looking at Telly, she's like, yeah, it looks like that it could be that the T wave is peaked, but let's get a 12 lead.
So how high was the potassium?
So how high was the potassium? We can make this a game, right? So how high do you think it was?
Greater than 6. I'm going to say greater than 6.
Ding, 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 ding. Yes, you won. Yes, it was greater than 6. 6.4. So, yeah. So seriously, we have a concern here, right? So she notifies the resident, and she's also, while she's waiting for the call back, she's being very proactive, and she's getting an ICU bed because obviously he cannot stay here. And so the resident calls back and says, okay, let's get an ABG and let's find out what his values look like. And so now the question becomes, what's going on with our patient? Why is this gentleman all of a sudden having AKI, basically? What has happened to his kidneys all of a sudden for them to shut down?
Do you think the vancomycin had something to do with it?
That was one. And what was maybe the second piece of that? So the vanc, because we know that is very nephrotoxic.
Right. Well, he was probably septic. And so the whole inflammatory cascade kind of upsets the system a bit too.
Yep.
Can cause some third spacing and poor perfusion.
You got it. And he has a long-standing history of hypertension, which he was not treating effectively. In fact, later on, when they talked to the gentleman and they were doing his discharge paperwork, one of the nurses had made the comment that he said that he takes his blood pressure medication when he felt like he needed it. And I think there are a lot of people.
Sense his blood pressure then?
I think there are a lot of people who may do that. I don't know. I think that may be a reality. And then also he has a history of heart failure. So those elements with the vancomycin, with the sepsis, which he was setting up, with the pneumonia, all of those things came together and created just a big cascade where everything came together and caused a hit to his kidneys. And so we got him upstairs to the unit. And so, we put these patients in the unit, and then we start to try to figure out, okay, well, what's going on with them, right? So one of the things we start to look at is, well, is he dry? Well, that's where the quality of the urine starts to come out. Well, was he making it? He wasn't making a lot of urine because we had that low volume output for the 2 days. They placed a Foley catheter on the patient. And so to see what's going on with this patient. And then the challenge becomes, do we give him fluid or do we hold fluid? Well, he's got a history of heart failure, and so he's diastolic dysfunction, reduced ejection fraction. We can give him some, but then how much do we give him? And then how do we administer that bolus? And then, so that would be our pre-renal question that we would have to look at and consider from a nursing standpoint. So that's where that urine output is going to be extremely important to understand. What are we doing with this patient? How much volume are we giving? And just because they say, hey, administer that bolus, what's some of the things that we should be doing? We should be auscultating those breath sounds and those heart tones as we're given that bolus to see how are they responding to it. Because you remember Frank and Starling, you fall off the backside of that curve, and what happens now? You're in flash pulmonary edema, particularly in a fellow like this. We start to give the medications a little bit, and we say, well, gosh, we're giving them volume. We're a little bit concerned about this. So the physician orders a Lasix challenge. So they decide to give him some Lasix. And we see that a lot, right? In the unit, say, let's give a Lasix challenge and let's see why he's got this going on. The idea behind the Lasix challenge is pretty straightforward. I don't know that it's one of those things that was explained to me in nursing school, along with why is urine output important. So we give the Lasix a challenge, and we're looking to see, do they make pee? Do they make urine? And yeah, that's the important question. Is the Lasix working? So here's the piece that becomes important. If the urine output is greater than 200 mLs in 2 hours, it gives you a good idea of what's going on. It's possibly that the cause of the low urine output was from a couple different things. One, could have been really dry. Or it's possibly that he had too much volume on board and he was third spacing. And if he was third spacing, this is going to help to pull it through. If he pulled it through and you get that 200 ml output in 2 hours, that tells you, you know what? The kidneys are still working. They're still alive in there. Those nephrons are working. Everything's going pretty well. So there's still hope. And then, of course, the last piece, if we had looked at this patient, is there a post-renal cause for this? And one of those things, if he had a Foley catheter in, is it possible that this patient had some sort of an obstruction, or was there a stone setting up or something like that? Now, with this particular patient, what they found was it was exactly that. He had gotten sick. He had also come into the hospital. He was a little hypertensive in the moment. Rather than considering it, the resident had started him on some antihypertensives. They dropped him a little bit too low. And with that, that started to impact his kidneys. And so the question becomes, if you're going to drop the blood pressure, what's a good rule of thumb? What should we be shooting for in that sense? And the literature's a little murky sometimes, but the consensus from all the literature that pretty much says the same thing. Literature suggests if a person who normally lives greater than 65, if their MAP is in that 50 to 55 range, they can tolerate that before their kidneys start to have some sort of an impact, only for about 10 to 30 minutes. So the idea of a MAP of 65 or better, that's a great target blood pressure. And then the other piece is that we want to avoid dropping the blood pressure more than 40 millimeters from their baseline. When you go more than that, that's when the kidneys start to be affected. So if we have a patient with a blood pressure of 210/100, we would not want to drop him less than 170 for a systolic.
Because his renal arteries are used to a lot more pressure to get the blood through them.
Yep.
You take that pressure away, they're like, hold on.
That's right.
That's not working for us.
Yeah,
we're used to much more support here.
That's right. Yeah, give me some love. There's no pressure here. Yeah, that's right. So, and that's what kind of brought this. Good news is the team at this particular hospital took great care of this patient. He went home, did well, got on an actual good regimen with his blood pressure medication. They did some great teaching with him, and now he understands. So I'm told that you can't just take it when you feel like it. You need
take
it
your
every
pill,
day.
your
That's
hypertension pills, PRN.
That's right.
When you feel like it. So how did he do with the Lasix challenge? Did he make that 200 mLs of urine they were hoping for?
He did. Yeah, he did very well with that urine challenge. And that kind of leads into that whole question about urine output and the Foley monitoring that urine closely, right? It does become a challenge. Real life nursing is, and we've all been there, you get tied up in a room for 4 hours. What ends up happening, and I've seen it in many places, 4 hours go by and the patient has a urine output of, say, 800 over those 4 hours. And people want to record it accurately as best they can, but they'll go 200, 200, 200, 200, and they'll say, that was what it was out because I was out for 4 hours. That's probably a good representation. I don't think anyone's trying to deceive anybody, but it's more like we get into this idea in our heads where we just got to fill in all the boxes, right? And so having that important knowledge, though, of what's going on with this patient and looking at the urine output, because as the urine output starts to decline, that's where we start to understand the kidneys are being impacted. So it could have been a situation where the patient has 400 mLs out, then they have 200 mLs out, then they have 150 mLs out, and then they have 50 mLs out. Okay, that's a little bit different. What's going on? And that's where that early indication, that prediction is going to help us to say, hey, things are going sideways with our patient long before we get in a situation where they become hyperkalemic and they start to have other complications.
Right. I mean, the case you described is such a perfect storm that honestly we see all the time. Like you had said, nurses are busy with 3 and 4 patients, but some med-surg nurses, they have 6 and 7 patients. Yeah. And they're probably just assuming, the nurse tech emptied the Foley or the nurse tech, documented the urine output. And they have so many other things, meds to pass, assessments to document, doctors to call. I mean, they're running around tasking like crazy. And so sometimes the realization of, oh my gosh, they've only peed 150 cc's in 2 days, it's not at the forefront of their mind because there's so many other tasks to be done. I mean, it's unfortunate because honestly, we see this all the time, all the time. Patients come in, they're septic, now their blood pressure is lower. Patients come in, they're septic, and we start vancomycin. Patients come in, they're septic, and we flood them with fluid and we congest their renal system. I mean, we're doing things to try to help. Antibiotics are good. Fluids are good.
Right.
However, sometimes it hurts. Pee is so important. And just like we have core measures for caring for heart failure patients, septic patients, stroke patients, hospitals have to report out their compliance with those standards. I hear that starting October 2024, so next month, CMS is including AKI as a reportable measure. What does this mean for hospitals? And more importantly, what does this mean for patients?
So the good news is they're asking us to start to look at it and start to figure out a plan. So the measure is this. In the future, and they don't really have an exact date as when this will start, but they want us to start to look at collecting data on our current trends with acute kidney injury. And so the idea is if the patients come in and they develop stage 2 AKI or greater using the KDIGO scale, then the hospital is at risk for a fine down the road. Not initially, but down the road. So that has a lot of implications for us if you think about it. And we can talk about those in a second. So the idea is that they come in and we start to collect data and let's find out how big a problem is acute kidney injury nationally. Well, we know that up to 30 to 35% of these folks could come in and develop an acute kidney injury while they're here. They may come in with it. If they come in with it, okay, the hospital's not going to be at risk. So the idea is let's collect the information. Let's see what the prevalence of this is. And then from there, we're going to start to assign some responsibility because patients come in and we should not make them worse. We should make them better. Where does this come from? This all comes from the hacks. So, the current hacks that we have, the PSI 90, you probably get emails at the hospital saying, hey, you had a pressure injury. Hey, you had acute kidney injury. That's already there. And depending on the size of your hospital, you could be at risk even now with those hacks of up to $1 million if you don't hit the metrics. And so you think that's a lot of money, and it is. Think about how many awesome nurses we could hire with $1 million. I mean, that would be phenomenal. You wouldn't have to worry about staffing, and you wouldn't have to worry about comp because we got $1 million we're saving here. So they're looking for us to collect this data and then with that come up with solutions. And so let's look at where do we encounter this? Well, one is in my area particularly, and we're working with our anesthesiology team, and they're an amazing group of men and women who we looked at it and we said, okay, on induction, patient comes in, we induce them with anesthesia, and we know that their blood pressure is going to drop. How do we monitor that blood pressure? And then how do we make sure they're not getting into trouble while they're in surgery? What's their magic map? Is their map 70? Is it 80? Is it 65? That's where having a great model of care where we know, hey, in the future, we need to be aware of this. So we've got to use our data at the best of our ability. What does primary care say about Mr. Jones? What's his normal blood pressure? Where does he live? That gives great information for us on the anesthesia side to look at it and say, okay, we're going to keep this gentleman a little higher so that he doesn't get into trouble. Close monitoring is going to be a key, but then there's also implications as well. What do we do about the patients coming into the ED? Does this automatically mean on admission these folks should get a BMP? That's a question we're going to have to answer because we don't want to get in a situation where our patients are developing AKI and that we're at risk. And so that's the big challenge.
So just like hospitals are being held accountable for pressure injuries that we caused and UTIs that we caused, now we're looking at maybe in the future being held accountable financially for AKIs that maybe we caused because we weren't paying close attention to them.
Correct.
Yeah. I mean, this is hard stuff, but accountability is good for patient outcomes. Like, we've seen CAUTIs go down. We've seen pressure injuries go down when we're being held accountable to doing the interventions to prevent them, right?
Yeah.
I mean, I'm glad the literature is showing us that urine output is this critical yet often overlooked early sign of clinical deterioration.
Yeah.
But to be honest, Tom, like, there's a lot of challenges inherent in traditional Foleys and their ability to provide accurate urine output monitoring. Can you talk a little bit about your work with Accuryn and how they've been a game changer in early detection of AKIs?
Yeah, absolutely. So Accuryn has been a game changer in so many ways. What they have done is they have essentially sat down, they brought the engineers in, they've sat down with nursing, they've sat down with physicians and said, tell us what you need. As opposed to companies coming in and saying, here's what you need. They come in and say, what do you need? And they developed a product that takes all of the information that we want to have at our fingertips, and they start to say, okay, we can do this for you. So one of the things we know, and you mentioned it, UTIs. We get hit now with UTIs. We're eligible for fines for that, and appropriately so. When you come to the hospital, why are you here? You're here for expert nursing care, right? And we should be able to take great care of you. Well, we know that people who have a Foley, they're at greater risk for a UTI. The literature's replete with that. We know that. One of the things we know that is a challenge is when we have that urine that remains in those dependent loops, right? We get that titling back and forth, or we get that retrograde flow. We take them down to CT scan and we're moving them around, and that we get that retrograde flow coming from the Foley catheter and from the urimeter. How do we deal with that? So what they did is they actually came up with a process, and no one's been able to do this yet, where they have active line clearance. So those dependent loops, they go away. Amazing. Great. I don't know how they do it. I'm not an engineer. I'm just a nurse. But you know what? This is what I know. It works. The second thing that they've done is they have developed this ability to measure the urine, and you can set the intervals, how far back you want to go, how frequently you want to look at it, and it tells you what the urine output is. Amazing. So if you want to know what it was every 15 minutes, every hour, every 2 hours, you can do all that. That's not a big deal. We can do that. Third thing, rather, that they're able to do is they're able to use information and collect it, and they can predict an AKI from developing almost 30 hours ahead of when it develops using clinical data. Another thing that is exciting about this particular product is that, in the ICU, we have these patients who come in and they have abdominal trauma. We've got to measure their intra-abdominal hypertension to make sure that we're not causing other problems. They have developed a Foley catheter that connects with their system that you don't have to set up. And if you've been doing this a minute like I have, you remember the days you had to hook up a pressure bag, zero it to the my gosh, zero to the pubic symphysis, and you can't have this, you can't have them move, they can't hold their face a certain way, and their tongue has to be straight, whatever it is. And you have to do this, right? And it's really hard. And then we're instilling this saline into the bladder. We're looking for a waveform, and then we take the number. They solve for that. You flip a screen and it tells you this is what it is. Here's the best part, though. And this is, I think, where nurses love this. The nurses I've worked with, they tell me this is the best thing. You don't have to write down the numbers. It will take the data and slave it up into your EMR for you. You don't have to go and do another step. It's there. You just acknowledge it.
Wait, hold on. There's technology that will document my patient's urine output for me accurately?
Shocking. All you have to do is accept the value into your EMR. Yeah.
What?
I know, right? How crazy is that? So
sign me up.
That was what I said when I heard about that. Were our folks in anesthesia and also for the bedside nurse. You think about these patients on isolation. One of the things that they have that is available is a tablet, like an iPad. And You can take the iPad and, your patient's inside the room, you're outside the room. Maybe they've got some sort of infectious process going on. You can log in on your iPad and take a look at what your patient's doing from a urine output standpoint. For the anesthesiologists, for the CRNAs, that iPad is great because you don't have to climb underneath the drape and look to see, hey, how's their urine output? You can see it right there on the display in real time. So
I love it.
They have listened and they've said, tell us what you need, and they've created it. So that's what I've encountered with them. And we have used it in different hospitals that I've been at. I'm a big fan of it because it makes nurses' lives easier. It protects the patients. And for me, those are the two most important things. My job as an administrator, I no longer do I take care of patients every day. My job is to take care of the nurses and give them the tools they need so they can take care of the patients. That's my job now. And so seeing something like this, a product like this, it's easy to get behind as a leader.
I mean, it's very rare to find a product that not only helps patients, but also decreases the nursing workload. Usually it's like one or the other, or like they cancel each other out. Like It's better for patients, but more work for nurses. But this is like a double win. That is awesome.
Right.
So my next question is, this does sound awesome. As a nurse leader, if a nurse is like, man, I would love to have something like this at my hospital, what advice or recommendations would you have for them to help bring technology like Accuryn into their facility?
The first thing is to sit down and have the conversation about why urine output's important. Unless the administrator is clinically based, and a lot of them are not, they're wonderful people. They're extremely intelligent folks, but they're not clinical, right? And they don't understand all of the elements that we look at one time, whether you're on the floor or in the ICU. And let's be honest, the patients who are on the floor today, 10 years ago, they were in the ICU, right? We're doing things out on the floor that if someone were to say to us 10 years ago, oh, hey, they're going to be on the floor, you'd be like, you're insane. That's not going to happen. But we know that it is happening. So we sit down with them, we say, this is why it's important. The next thing is a lot of these folks, they are responsible for the bottom line. They're responsible to make sure that we as a healthcare organization stay afloat. And with all of the different hacks and all the different penalties and all the requirements and the cost of equipment and the cost of medical supplies, they're always looking at the bottom line. And so this is where you start to say, this is going to help you. It's going to help you from a few ways. One is incremental overtime. Those are key words, incremental overtime. Because what happens is if I'm the nurse and I'm staying there and I've got to add up all my urine and I've got to add up all my I's and O's and all that, and you know what? That takes time, because we all know that the busiest time of the shift is from 4:30 until 7:15. And people want you, they want your attention, they want you doing things. Well, at the same time, you're trying to get your patient package up, you're trying to wrap up your shift, you're trying to make sure everything was done so you hand off a patient that is pristine to your partner coming on behind you. So incremental overtime, this will help to decrease that. The second thing is going to help us to avoid catheter and fully catheter infections, UTIs. UTIs are reportable. They are also money. That's exactly right. Money. And so that's another thing. Now they'll say it's soft dollars. And your answer is, yeah, it is soft dollars. But you can't buy advertising that's worth more than a good story. Because on the backside, for every UTI, there's somebody who's at the Walmart or at the Kroger saying, my mama went to hospital X and they gave her a kidney infection. Well, maybe not. But the thing is that those are the things that people remember. We want to do great care every single day. We come in every day. We do a great job. This is a great tool that is affordable. That is something that is going to be a game changer for the lives of nurses, for patients, and really for the overall organization.
Yeah. So let me just get this straight. It helps nurses.
Yeah.
It helps patient outcomes. And over time, it will also help the bottom line of the hospital.
Yeah.
Especially if CMF starts putting fees attached to AKIs. If we can prevent those, that's a great bargaining chip
It's a
when
great
talking
tool.
to admin, saying, hey, this is on the horizon. Are we prepared to report out our AKIs and have them look good?
Yeah.
Do we have the tools and resources we need to early detect and protect our patients from AKIs?
Yeah.
So yeah, this is a good discussion, Tom.
Yeah. And listen, the main thing is, and you said it, the most important thing, it helps nurses. Well, let's just stop right there. That's enough in itself, I think. But as a nurse, I say that. I'm biased.
little biased there. Oh, Tom, this is such a good discussion. Can we just take a moment? I wanted to summarize all of the knowledge nuggets from this episode. So if you were teaching, say, new grad Sarah, who all I knew was just notify the doctor when the urine output's insufficient, what are like the key takeaways you'd want me to know about the why behind why we want to do close urine output monitoring?
Okay. So new grad Sarah or student nurse Sarah, here's what we need to know. One, urine output's very important because it's a great indicator of perfusion. It tells us how well those kidneys are being perfused. So that's the first thing. Second thing is it tells us if our patient's getting into trouble. Are they developing an acute kidney injury? And so what are we looking for? We're looking for an increase in serum creatinine of more than 0.3 mLs per deciliter an hour, for within 48 hours. Or are we looking for an increase in the creatinine of 1.5 times above the baseline? We're looking for that urine output to be at least 0.5 mLs per kilo. We need it to be that so that we know that the patient is perfusing adequately and they're moving waste out. They're not going to start the third space and develop other problems. And so those are some key takeaways for us, because if the kidneys go down, then everything else is going to start to follow.
Nailed it. You summarized it so well, Tom. Thank you so much for your time today. This has been such a good discussion. I feel like we hit on some really important stuff, both for like patient outcomes, but also like nursing advocacy. Like our role is so important. It's also so hard, but I love that there's tools like Accuryn that can help us do our job well and advocate for patients well. We have technology to like justify our advocacy when we're speaking up and saying, I have numbers to show my patient's declining. We need to get interventions going. So this is a great discussion. All right. Well, that's all I got for today, Tom. Thank you again for your time, and I hope you have a great weekend.
You too. Thanks. Good to see you.
Thank you.
All right. Bye-bye.
Bye. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.